I think cardiovascular medicine is becoming highly mechanized. I mean, a lot of everything is, the noise is being made about percutaneous valve replacements, about greater efficiency and efficacy in arrhythmia termination, EP, greater ability to revascularize. So really, this is where the glory is in cardiovascular medicine, which makes the mundane thing that requires face-to-face conversation, and that requires behavior modification, and that requires not just immediate gratification. You know, I walk in, I can't breathe, I have chest pain. I walk out, I no longer have chest pain. That's what patients want, and doctors like that. I think it's important that we realize that there is the process that atherosclerosis is. It's diffuse. That if you go in and you fix a severe blockage, it doesn't mean that upstream or downstream there isn't one that is now rehearsing for its role to become severe. And the literature supports that within, say, a year to a year and a half, one of those previously unsevere lesions is going to graduate and become a severe one. So then you get a chance to sort of develop a full metal jacket, where when you look at someone's coronaries, there's one stent and another stent and another stent. So I think that there's a role for this. And I think that the finances of medicine are such that those things are really expensive. Every time you walk in and someone lies you on a table, you spend 24 hours in a hospital having the procedure done, it can cost you 50 grand. You can buy a lot of medicine for that kind of money. And if the quality of life is not necessarily better, if you can make someone feel good with medicines, and importantly, prevent death, which is a bad thing to have, and prevent stroke and MI with medicines, why not do it? We need to do something in the continuum of obesity and inactivity is the incidence in diabetes. And I find that there are certain words that you can tell patients that gets them nervous. And when you mention the word diabetes, everybody knows somebody who's been amputated, who's had a stroke or an MI or multiple ones and become an invalid. And I think that I don't have any hesitation to look for the pre-diabetic. I think it's important. I think it allows for some degree of adherence and compliance, which you wouldn't get if I tell somebody, look, you know, you're overweight, your triglycerides are high, your HDL is low. If I sell the same thing and you're pre-diabetic, or that you're a Hershey bar away from becoming a diabetic, that gets their attention a lot more. And that is something that I think is important. And the other thing I think that we don't grab enough of is stroke prevention. And that realistically speaking, people aren't that afraid of heart attacks anymore, because they know people that have had them, and they're playing tennis or doing whatever they want to do a month later. Whereas strokes are something that scares the bejesus out of people for good reason. So I think using everything that we do to prevent heart attacks prevents strokes. So I kind of cheat and I use that as a motivator, and I find that those two things, diabetes and stroke, have a habit of opening people's eyes, making them more receptive.